Okay, let us continue. Raise your hand if you're able to hear me clearly. Okay, that's good enough. So we have completed the first section of airway management, which focuses heavily on the anatomy and physiology, the pathophysiology, and how to assess the upper airway, which centers around you check the patient's level of consciousness, you position the airway, ensure it's clear, look, listen, feel, simultaneously check for a pulse if your patient is not corresponding with you, and when to use your airway adjuncts and suctioning. The next section of the chapter will focus on oxygen administration and the use of positive pressure ventilation with O2. So we're going into supplemental oxygen administration now. Now, the first thing you need to understand is that oxygen is a medication. So it is a medication. So there is an indication for its administration. And any patient that is showing signs of hypoxia or respiratory distress, we will administer high or low flow oxygen, or if they're having failure or arrest, we would administer positive pressure with high flow. So there must be an indication. So you have to assess the patient and determine that it's indicated, and then give the patient the medication. So it's a medication. If you give too much, it can cause an issue. If it's not given when it's needed, it can cause an issue. So you cannot over-oxygenate your patient. It can cause problems. So let's ensure that we have that understanding first before we go into the equipment. The red blood cells can only hold 4 oxygen molecules. So if they are properly oxygenated and you give the patient oxygen, the oxygen molecules that you're introducing into the patient's bloodstream has no blood cells to occupy, so they become free radicals, and they can damage the blood cells that already have oxygen molecules attached to them, and they can lose their oxygen molecules. So that's one. 2, if you over-oxygenate your patient, it can also cause the cerebral arteries and the coronary arteries to vasoconstrict. So it can cause these arteries to lock up if too much oxygen is available, because the body can only allow 1 cell at a time to pass through the capillaries. Can have too many, that can cause problems. And if the cerebral arteries and the coronary artery vasoconstrict when the heart and the brain needs blood, that can cause problem for a patient. So it can become free radicals, and it can cause vasoconstriction. So it can cause the blood vessels to lock up or get constricted, that supply the heart itself with blood and the brain. The over-oxygenation, so if you over-oxygenate your patient, it can also wash off nitrogen. So there's a certain amount of nitrogen that is necessary in the body. That's why we don't walk around with a pulse oximetry reading of 100%. Our readings fluctuate between 95, 96, 97. We don't walk around with 100% oxygenation. The other percentage is nitrogen and CO2. The nitrogen is necessary in the body for your body to make what we call surfactant. So nitrogen contributes to surfactant. It is an important component of surfactant. Surfactant is necessary for the alveoli to have elasticity. So the surfactant is like soap sud. Think of it as soap sud. It allows the alveoli to recoil when we breathe in and out without closing. So it keeps the alveoli open and it allows permeability at that level. If the nitrogen is washed off, meaning the wet nitrogen is reduced, the surfactant is going to be washed off and the alveoli will collapse. If the alveoli is not open, the patient cannot get good respiration. And when an alveoli collapse, it allows the availability of more surface area for bacteria to invade. So again, we're not going to over oxygenate the patient. We're going to assess the need and determine what is most appropriate. So if a patient don't need oxygen, we don't give oxygen. So medication. All right, so supplemental oxygen. Always give oxygen to patients who are hypoxic. Some tissues and organs need a constant supply of oxygen to function normally. Never withhold oxygen from any patient who might benefit from it. Supplemental oxygen equipment, so you need to be familiar with the supplemental oxygen equipment, become familiar with how oxygen is stored. Oxygen cylinders contain compressed gas, and that is what is more commonly used in EMS. Liquid oxygen is becoming more commonly used alternative. I have not seen liquid oxygen taking over from the oxygen cylinders. Now, the safety considerations. Handle gas cylinders carefully. Make sure the correct pressure regulator is firmly attached before transport. A puncture hole in a tank can turn into a deadly missile. Secure cylinders when stored on ambulance and when in use during transport. Now, the oxygen cylinders that are used in EMS, and you have, the smaller cylinders will have green and gray, green and a grayish color. Some will be full green. And the large oxygen cylinder is going to be black and white. That's the one that is stored on the unit. The portable cylinders, which are smaller, tend to be green and gray. Now, the small cylinders utilize what is called a pin indexing system. So what that means is there is a specific regulator that attaches to the oxygen cylinder using a pin indexing system, meaning there are pins on the regulator which lines up with holes in the cylinder. So that regulator can only fit on that type of oxygen cylinder, and a regulator is needed because when a tank, an oxygen cylinder is filled, it is 2000 psi. We cannot give a patient 2000 psi. Their lungs cannot handle that type of pressure. So what the regulator does is it reduces that pressure to about 70 or 50 psi, and then we can release it at a desired flow rate for the patient to utilize. So that's a pin indexing system. The larger cylinder uses a similar system, but it is referred to as the American indexing system. Right, so pressure regulators reduce the cylinder's pressure to a useful therapeutic range, usually 40 to 70 psi. Final attachment for delivering gas is either a quick connect female fitting or flow meter. Flow meters usually permanently attached to the pressure regulators on emergency medical equipment. I have the pressure compensated flow meter. You will see that one more in the hospital setting. That's the one with the ball. So when you turn up the flow rate, the ball goes up. And you have the burden gauge or gauge flow meter, which is the one that is used more commonly in EMS. Now, hazards of supplemental oxygen. Combustion, so oxygen supports the process of combustion, and you have to be mindful of oxygen toxicity. So we cannot give the patient too much oxygen. It can cause complications. Combustion, oxygen does not burn or explode, but it does speed up the combustion process. Keep any sources of fire away. Make sure the area is adequately ventilated. Never leave an oxygen cylinder unattended. Oxygen toxicity. Not all patients need high concentrations of oxygen. Oxygen can have detrimental effects in patients with certain illness. Example, COPD. A COPD patient relies on their hypoxic drive to breathe, so they are stimulated by low oxygen levels. So in theory, if we introduce these patients to high flow oxygen too early, it can reduce their hypoxic drive and they stop breathing. Also, we need to watch out for introducing free radicals if the patient is already properly oxygenated, and we can cause vasoconstriction of the cerebral and coronary arteries, and we can wash off the nitrogen or surfactant, which is important to the alveoli. When pulse oximetry is available, tailor oxygen therapy. Administer the minimum amount necessary to maintain oxygen saturation at or above 94%. So we will start at the minimum end and gradually increase if we need to. And any patient with a pulse ox reading below 90% with altered level of consciousness and trouble breathing will require high flow oxygen. If the pulse ox is above 90 and they're still communicating with you okay and they need oxygen, then going with low flow is acceptable. All right, now the oxygen delivery equipment. So you have your non-rebreathing mask, you have your bag valve mask, and you have your nasal cannulas. Non-rebreathing mask is a high flow device. You also have what is referred to as a partial rebreather. So you have non-rebreather and partial rebreather. Both are high flow devices. A bag valve mask is a positive pressure device. And then you have your nasal cannula, which goes into the nose, is a low flow device. Now, the non-rebreathing mask is the preferred way to give oxygen in the pre-hospital setting if your patient requires high flow oxygen. You can also use a partial rebreather, right? So the non-rebreather can give you a flow rate of 10, 12, or 15 liters per minute. So it can give you close to 90% oxygenation. It's called a non-rebreather because it has valves on it. It has valves that seal the certain openings on the mask. So the patient is only getting pure oxygen. The partial rebreather, one of the opening has no valve. So one area has valves that seals that area, but another area, the valve is absent. So the partial rebreather is giving oxygen, but it mixes with the outside air. which is important for some patients. Now, as I mentioned, both non-rebreather and the partial rebreather are high flow devices. Now, when we decide to use a partial rebreather, is something to consider. So we will use a partial rebreather in two circumstances, and this is just in two circumstances. One, if you have multiple patients. So if you're dealing with multiple patients that require high flow, go with a partial rebreather, because the partial rebreather, if the oxygen finishes, it won't suffocate the patient. If it's a non-rebreather and the oxygen finishes, it can suffocate the patient. It can form a complete seal on the patient's face. The other situation in which we will use a partial rebreather is if the patient is having a panic attack. So if they're having hyperventilation syndrome or a panic attack, so they're breathing very fast because they're nervous, or they got bad news or anything like that. It's causing them to breathe very fast and they're not controlling their breathing, so they're hyperventilating. In the hospital setting, and in some, well, I've never seen it in a book, to be honest, but in the hospital setting, in Jamaica, because I've never seen this in the States either, you will see them using a paper bag for the patient to breathe. In EMS, we don't give a patient that is hyperventilating a paper bag. Now, I'm not saying that the paper bag won't work. It's just something that we do not do in the pre-hospital setting, and there are reasons why we don't do it. So if a patient can be hyperventilating and it is not necessarily a panic attack, they are hyperventilating to compensate for a metabolic acidotic state, right? So let's use a Cosmo Respiration, which is the most clear example I can use. So the Cosmo Respiration is a patient that is breathing rapid and deep. So this is a patient that might appear to be hyperventilating. What their body is doing is breaking up the acid into CO2 and water. If I give this patient a paper bag to rebreathe in, they're going to be rebreathing the CO2, which will make the metabolic acidosis worse. And eventually this patient is going to lose consciousness. In the pre-hospital setting, it's safer for us to use a partial rebreather, because the patient can get the oxygen that they need and they're getting rid of the CO2. That's why we use it in the pre-hospital setting. So you will not see EMTs or above that level using paper bag in the pre-hospital setting. It's not a part of our treatment protocols. So that's your non-rebreather and your partial. And the partial rebreather can give you 6 liters per minute. It can give you 6, 8, or 10 liters per minute. We don't exceed 10 liters per minute with a partial, because you would be wasting oxygen at that point. The reservoir bag on the non-rebreather or partial rebreather must be filled with oxygen before you put it over the patient's face. And if your patient is responsive, you communicate with your patient. Sir, ma'am, gonna be putting a device over your head or over your nose and mouth. It's gonna help with your breathing. If you're feeling any discomfort or you start to feel nauseous, like you want to vomit, please let me know. So explain to the patient what is happening. And if your patient is having a panic attack, don't just fling a partial rebreather on the patient. You're gonna have to coach the patient, right? So don't just throw the device on the patient. You're gonna have to communicate with the patient. Sir, you're gonna have to control your breathing. No, I can't. Yes, you can. You can control it. I can't. Yes, we're gonna do it together. You're gonna work with me. I can't. Yes, we can do it. Let's do it together. You're gonna take a deep breath in. You're gonna exhale on my count until I reach 1. Can do it. Try, man. We can do it. Come. Deep breath in. In 5, 4, 3. You let it go. We almost made it to 1. Come again. Right? So you need to calm the patient down if it is a panic attack before you put the device on the patient. Now, please note, let me just put this out there. Not every patient that is breathing fast is having a panic attack. That's why we ask about chief complaints and stuff like that. So not every patient is having a panic attack. So there are some patients who might be breathing very fast and you cannot calm down that breathing because it's not a panic attack. There's something else wrong that is causing that patient to breathe fast. So just keep that in mind. Make sure the reservoir bag is full before placing the mask on the patient. Adjust the flow rate so the bag does not collapse when the patient inhales. So with a non-rebreather, you're looking at 10 to 15 liters, and we will start on the lower end. So we tend to start on the lower end and we gradually go up if necessary. When oxygen therapy is discontinued, remove the mask. Now, if you're going to change over or discontinue oxygen, do not turn off your oxygen with your device on the patient. Remove the device first, then turn off the oxygen. So take off the device, then turn off the oxygen. Do not turn off the oxygen with the device on the patient. All right, now the nasal cannula is a low flow device. Deliver oxygen through 2 small tube-like prongs that fit into the nostril. It can provide 24 to 44% inspired oxygen when the flow meter is set at 1 to 6 liters per minute. So the range for your nasal cannula as an EMT, and I will say as an EMT because it can go above that depending on your level of training. So 1 to 6 liters is your range in the field, right? So in the field, and this has nothing to do with textbook. So 1 to 6 is your range, that's a textbook question. In the field, you will not exceed 3 to 4 liters in the field. So if you have to go above 3 or 4 liters with a nasal cannula, might as well you give your patient high flow oxygen. So do not exceed 3 to 4 liters. The nasal cannula goes into the nose. You're administering oxygen. And if it's not humidified, it's going to be dry oxygen, so it can irritate the mucous membrane. So above 3 to 4 liters with nasal cannula is going to start to dry out the mucous membrane if it's not humidified. So work with the 3 to 4 as your range. When you anticipate a long transport time, consider using humidification. Now, humidification is necessary to make the oxygen moist and easily absorbed. And we will use humidification for patients who need oxygen with a history of upper or lower respiratory tract infections. So patients with infections tend to get dehydrated. So if you give them dry oxygen, they might have issues absorbing that. So the humidifier helps to moisten the oxygen so they can breathe it in better. If you have a patient with suspected airway burns, they will benefit from the humidified oxygen. You need to give oxygen over extended period of time. They will benefit from humidified oxygen. And humidified oxygen mean when you look at the cylinder, for persons who are not aware, there is a canister attached to it with water inside of it that the oxygen goes into and then goes into the oxygen tubing. So it enters the canister first, becomes humidified, and then it goes into the oxygen tubing into the patient. And we're famous for keeping that canister on the device, which it's not supposed to be like that. So in the pre-hospital setting, if we need to give the patient humidified oxygen, we start them on dry oxygen first. When we get to the unit, then we put them on humidified oxygen. So we don't give humidified oxygen in the field unless the patient is stuck and requires it, or there is a long distance between the patient location and the unit. Outside of that, it's dry oxygen until we get to the unit, then we give the patient humidified oxygen. Because if you have a humidifier on your portable cylinder, your cylinder must be in an upright position. And that is not an easy task in a chaotic setting in the field, right? So we wait until the patient is inside of the unit. Now, the humidifiers that I've worked with in the field, in the States, are one-time use. It's not for multiple patients. I do believe you have, there are humidifiers that can be used more than once. I might not be sure, but ones I've seen is one-time use. Now, if you're gonna keep a humidifier on the unit, which is commonly done in Jamaica, it needs to be kept clean, right? It's something that needs to be kept clean. If the port is open to the atmosphere, microorganism can get into the canister. So if you leave it on the cylinder and it's not clean, and you're gonna give a patient oxygen with that humidifier, you're introducing microorganisms into the patient lungs, and then we start to wonder how the patient get pneumonia when they might try to recover in the hospital. So it needs to be clean. The water needs to be changed on every shift. So it should be changed on every shift, and it's sterile water, right? Sterile water you want to use, or boiled water. Let me not get too technical. So the water need to be changed, the canister need to be clean, they put more water in it, you don't need to fill it, at the minimum level is fine. If it's too close to the maximum, if there's any tilt in the cylinder, the water can get into the line, that can get into your patient lungs. We don't want that happening either. So the humidifier is necessary for long transport time. Patients with upper or lower respiratory tract infection that requires oxygen, patient with airway burns. We do not use the humidifier in the field. We use dry oxygen in the field, and then we use the humidifier on the unit. And the reason for that is mobility. It's an environment that is very dynamic, and we have to move around and move things around. And no matter how much you tell people, don't go close to that cylinder, somebody's gonna bounce against the cylinder. And if it drop and the stem crack, you have a missile if it's a full cylinder. Right? So for safety purposes, if we're going to keep the humidifier on the unit, which is commonly done in Jamaica, it needs to be kept clean. Must be kept clean. If it's not being kept clean, you're introducing all type of organisms into the patient lungs. Okay. Now the partial rebreathing mask, I've talked a lot about this already. Similar to the non-rebreathing mask, there is no one-way valve between the mask and the reservoir. The patient rebreathes a small amount of exhaled air. It is very advantageous to your patient with hyperventilation syndrome or a patient that's having a panic attack. The Venturi Mask, I've only seen this in the books, so I've never seen it in an ambulance service. Over the 20 years I've been in EMS, I've never seen one in person, only in the books. But this is a mask in which, based on the connector, you're able to administer moderate to high flow oxygen based on the type of connector you have attached to the mask. It can be quite beneficial for a COPD patient, but again, if I don't have a Venturi mask, a nasal cannula can do pretty much the same thing. I don't need a complicated mask to be able to titrate from from low to high flow. Nasal cannula can do the same thing. And I guess that's why it's not very common in EMS. So it's medium flow devices that deliver 24 to 40% oxygen, useful in long-term management of physiologically stable patients. All right, now the tracheostomy mask. Patients with tracheostomies do not breathe through their mouth and nose. They breathe through the tracheostomy opening, and the opening is right where the cricothyroid membrane is. So they have a hole in the neck, and a tracheostomy tube is in that opening. The tracheostomy mask covers the tracheostomy hole and have a strap that goes around the neck. It may not be available in an emergency setting. You can improvise by using a face mask instead and place at the tracheostomy opening. Humidification. Some EMS systems provide humidified oxygen during extended transport. Many EMS systems do not use humidified oxygen in the pre-hospital setting. Already stressed on that. For certain conditions such as croup or patients with upper or lower respiratory tract infection, because infection causes the body to dehydrate, they're going to have problem absorbing dry oxygen. So humidified oxygen would be beneficial to these patients. Dry oxygen is not considered harmful for short-term use. Now, assisted and artificial ventilation. So we have looked at the supplemental devices, your nasal cannula, your partial rebreather, your non-rebreather, your Venturi mask, your tracheostomy mask. Now let's look at positive pressure ventilation devices. So you have a term that is referred to as assisted ventilation, and you have artificial ventilation. Whether you see the term assisted or artificial ventilation, it is referring to positive pressure ventilation. Let me repeat that. So whether you see the term assisted or artificial ventilation, both terms are the same when we use the term positive pressure ventilation. Now let's differentiate the two. Assisted ventilation is when you have a patient with a decreased level of consciousness with poor chest rise. So you have a patient with a decreased level of consciousness with poor chest rise. if you have to breathe for that patient. So if you have to breathe for that patient, regardless of the device that you're using, whether it's a pocket mask, a face shield, or a bag valve mask, once you have to breathe for that patient, it is referred to as assisted ventilation because you're assisting the patient's ventilation to be adequate. So the patient has ventilation, but it's not good enough to give you good chest rise bilaterally. So when you breathe for them, it's to get good chest rise, but they're already breathing. It's just not adequate. So when you're breathing for that patient, you're assisting their ventilation. Artificial ventilation is when you are breathing for a patient who has no ventilation. So artificial ventilation is when you're breathing for the patient that's not breathing. That's the difference between the two terms. This is probably the most important skill in any EMS level, to be able to breathe for your patient. Absolutely essential skill. Basic airway and ventilation techniques are extremely effective if done properly. Follow standard precautions as needed when managing a patient's airway. So let's look at our devices. Assisting ventilation we assist ventilation in respiratory distress and respiratory failure and respiratory arrests. And this is where students start to have trouble. This is where EMTs start to have problems in the field. So when it comes to distress, failure and arrest is very easy to identify in a patient. So it's very easy to determine if your patient is in respiratory failure or respiratory arrest. Distress, though, a patient in distress can present 3 ways. So if a patient is in respiratory distress, they can present 3 ways. They can be in mild respiratory distress, they can be in moderate respiratory distress, and they can be in severe respiratory distress. A patient in mild or moderate respiratory distress is a patient that is still talking to you. So they are able to communicate with you. They can tell you what's happening to them clearly, fully oriented. They can talk to you, but they're having trouble breathing. So they might have a increased respiratory rate. You might see some muscle use. However, you're still able to see visible chest rise. And this is a key finding. Once you're able to see visible chest rise bilaterally for any patient that is having trouble breathing, that is defined as distress. Let me repeat that. So this is key now, people. This is very important. Once you have a patient that is having trouble breathing and you're able to see visible chest rise bilaterally, the type of breathing problem that they're in is referred to as distress. That is distress. So that's mild, moderate. So let me repeat again. Mild to moderate respiratory distress is a patient that is able to communicate with you, but they're having trouble breathing. So the breathing rate might be slightly elevated. You might be seeing some muscles being used at this stage, not severely, but definitely seeing a little muscle use. And the patient still has visible chest rise bilaterally. If the patient is in mild to moderate respiratory distress, the treatment will either be supplemental high flow or low flow. So it's either you're going to use your nasal cannula, your partial rebreather, or your non-rebreather. That's a treatment. And there are some patients in which you can use CPAP as well, continuous positive airway pressure. So that's mild, moderate. now severe. And this is where students start to get the question wrong, and this is where EMTs start to lose their patient in the field. So your patient can progress to severe respiratory distress. The patient can progress to severe respiratory distress. What am I looking for with a patient in respiratory distress? Now, when respiratory distress becomes severe, your patient can no longer maintain a good level of consciousness. That is key. So when a patient is in severe respiratory distress, they will no longer be able to maintain a good level of consciousness because they are starting to decompensate. You can see a breathing rate that's going up, that is severely labored, or more commonly, you will see a breathing rate that is coming down. You might even catch the breathing rate at a normal rate, right? So the breathing rate starts to come down. You are no longer compensating. You will see severe muscle use. So the patient is working very hard to breathe. There's a decreased level of consciousness. The breathing rate starts to come down. It can be up still, but most commonly you're gonna see it start to come down, and you can catch it at a normal rate. They can catch it between 12 to 20 breaths per minute for an adult. This patient in severe respiratory distress is close to what we would call failure. So the patient is about to fail on you. Because the patient is close to failing, we must anticipate that. So in the field, if I had this patient on high flow, I would now be getting ready to manage his upper airway with airway adjuncts and breathe for him, because he's going to get to that point if he's in severe respiratory distress. So I need to start getting my airway adjuncts ready, my BVM or pocket mask, my suctioning device ready, and anticipate that. In the field, that's the approach. If you see a question in your exam that gives you a presentation of a patient in severe respiratory distress, decreased level of consciousness, breathing rate coming down, severely labored, good chest rise present. So it's severely labored, but it's good chest rise. That's why it's classified as distress. The treatment is going to be positive pressure ventilation. So that would be the answer to the question. You breathe for that patient. In the field, we don't right off the bat start to breathe for the patient. We start to prepare to breathe for the patient. So that's the difference. If you see that question, the answer is going to be use your BVM or pocket mask and breathe for the patient. So that's severe respiratory distress. So just keep that in mind. Distress can be in the form of mild, moderate, and severe. The patient in severe, we will breathe for that patient. Right? That's the answer to the exam question. In the field, we prepare to breathe for that patient. All right, now respiratory failure and arrest, as I say, is very easy to identify. So a patient in respiratory failure, you will look at two key presentations, two key things in the patient presentation to determine failure. One, the patient's level of consciousness, and two, chest rise. Once your patient has a decreased level of consciousness with poor chest rise, that's respiratory failure. So poor chest rise is associated with respiratory failure. So to determine if your patient is in respiratory failure, you're looking for a decreased level of consciousness with poor chest rise. That's failure. For respiratory arrest, it is straightforward. Arrest means stop. That's what arrest means. So respiratory arrest is a patient who is no longer breathing. If a patient is not breathing, they're in respiratory arrest. If the patient has poor chest rise with a decreased level of consciousness, that's respiratory failure. If the patient has difficulty breathing with good chest rise bilaterally, that's respiratory distress. I am putting a lot of emphasis on this. It is key to managing your patient who is critical. Make sure you understand the concepts. Very important as we go forward. All right, now signs and symptoms of inadequate ventilation. First thing you need to look at is the patient's level of consciousness. Remember, once the patient has an incorrect response to person, place, time, and event, it is an altered mental status. There will be inadequate minute volume, excessive accessory muscle use, and fatigue. Now, when assisting with a BVM, if you're going to breathe for a patient, so if you're going to breathe for a patient with poor chest rise, and that patient is still breathing, you have to match their breathing pattern or synchronize with their breathing pattern for the first 5 to 10 breaths. What does that mean? It means if I'm using a bag valve mask and I am going to bag a patient with poor chest rise who is still able to move their chest, I will squeeze the bag when the patient is breathing in. I will not squeeze the bag when the patient is exhaling. So you watch the patient, and every time they breathe in, you squeeze the bag for 5 to 10 breaths and then take control of their breathing after that. We'll show you what that looks like when we come face to face. Now, artificial ventilation. Patients in respiratory arrest need immediate treatment to live. Once a patient is not breathing, begin artificial ventilation immediately. And the ideal device for artificial ventilation is mouth to mask technique. And all of you will be required to be present for your skill station with a pocket mask. So when we're gonna start our face-to-face, do not turn up without a pocket mask. There is a skill sheet for that, and you must be examined with a pocket mask. So start investing in one. You're gonna need it for your skill station. So the ideal technique is mouth to mask technique. Then you have your 1 or 2 person BVM. The 2 person BVM is much more effective than 1 person because you have 1 person who focuses on maintaining the seal while the other person squeezes the bag valve mask. And you have manually triggered ventilation device, which is not commonly used in BLS response, but it is in the book. Don't expect a lot of questions on that. It's not commonly used in BLS transport. Now, normal ventilation versus positive pressure ventilation. Now, anytime we are going to provide positive pressure ventilation for an adult who has a pulse and is not breathing, it is 1 breath every 5 to 6 seconds. And for your pediatric population, it is 1 breath every 3 to 5 seconds. And you want to be closer to the 3 seconds than the 5 for the pediatric population. This is a little slower than the normal physiology of breathing. Now, what you need to understand is when you're using a BVM, let me not say BVM, when you're providing positive pressure with a BVM, a pocket mask, or a face shield, you are going against the normal physiology of breathing because we breathe in with negative pressure. So if you provide positive pressure and it is too forceful or too fast, you can actually interfere with the venous return. So you can actually reduce the blood flow returning to the right side of the heart because the pressure inside of the alveoli is so forceful it causes the capillaries to flatten out, and that can interfere with the amount of blood returning to the right side of the heart. So we don't want to be too forceful when breathing for a patient, and we don't want to be too fast, and we need to ensure that the airway is properly positioned when we're breathing for the patient. And whoever is at the airway need to pay attention to what they're doing. So if I am responsible for the BVM, when I squeeze that BVM, I need to be looking at the patient's chest. I cannot be looking at who is beside me on my left or right. I need to be looking at the patient's chest. I need to see the chest rise. If you do not see the chest rise when you squeeze a BVM, the air went somewhere. All right? If you don't have an airway, nothing else matters. Now, with positive pressure ventilation, it's going to cause increased intrathoracic pressure, which reduces the blood pumped by the heart. More volume is required to have the same effects as normal breathing. Air is forced into the stomach, causing gastric distension. So if we're using poor technique, we'll get air into the stomach, and then you have a patient with gastric distension. Once you start to get air in the stomach, the diaphragm is going to shift upwards. So the diaphragm starts to shift upwards, and that will reduce the dead space as the diaphragm moves up. There is increased pressure in the chest. So when you start to squeeze that BVM, you're going to feel resistance. And if you start to force here when you feel that resistance, you're just going to make it worse. So it is very important that the proper technique is used. Now, when you start to practice, you'll discover that it is quite easily done on a mannequin. It's not like that in real life. So if you're not properly positioned in the airway, you're not going to get air into the lungs, right? And I'll show you where your fingers need to be in order to ensure that the airway is properly positioned when we meet face to face. Very important skill. Now, mouth to mouth and mouth to mask, we don't really use mouth to mouth anymore. You can consider that for family members or loved ones. We definitely use the mouth to mask. It's a very good equipment to have. Right? So if you're having trouble with your BVM that you go back to your pocket mask, because you can use two hands to maintain a seal with your pocket mask and breathe for the patient. Let me repeat, all of you need to have a pocket mask when you come to your face-to-face session. Start investing in one. Do not turn up and tell me that you don't have any, because I can't grade you if you don't have it. I need to see everybody use a pocket mask and make the chest rise. Okay. Now, signs of adequate ventilation. So this is how you're going to know if your positive pressure ventilations are working. The patient color improves. You will see the chest rise adequately. There should be no resistance. So if you're doing using a pocket mask or a BVM or a face shield, at no point you should feel resistance. You can hear and feel air escape as the patient exhales. Now, this is your bag valve mask. This is what it looks like. So it has a reservoir for oxygen, and it has a connection port that you can attach your oxygen from the cylinder. Once we're using a BVM, we do not go below 15 liters per minute with a BVM. Bag valve mask, most common method used to ventilate patients in the field, provides less tidal volume than mouth-to-mask ventilation. An experienced EMT can provide adequate tidal volume, but an inexperienced EMT can become your worst nightmare in the field for managing an airway if they don't know what they're doing. And I have had a few. So an EMT that is very comfortable with a BVM is the best thing I can have on my team. They will make my job easier. An EMT that doesn't know what they're doing is going to create all type of problems for the airway. If you have difficulty ventilating with a BVM, switch to another method. The volume of oxygen is based on observing chest rise and fall whenever possible. Work with your partner to provide BVM ventilation. So ideally, two-person is going to be the best way to use the BVM, but one EMT with good technique is worth more to me than a paramedic. All right, now gastric distension. It can occur when artificial ventilation fills the stomach with air. It most commonly affects children, but it can happen in your adult population, especially if the ventilation technique is being done poorly. Most likely to occur when you ventilate the patient too forcefully or too rapidly. And you cannot breathe for a patient with gastric distension. You're gonna have to turn them on their side and put pressure on the abdomen, and that pressure will allow whatever is inside the stomach to come up, and as it come up, you clear the airway. But you cannot breathe for that patient until you have relieved that distension, and that is gonna delay your management for the airway. To prevent or alleviate distension, ensure the patient's airway is appropriately positioned, ventilate at the appropriate rate. It's 1 breath every 5 to 6 seconds for your adult, 1 breath every 3 to 5 seconds for your pediatric population, and you want to be closer to the 3 seconds. Ventilate with appropriate volume. If the stomach appears distended, you may have to reevaluate your airway. If it's still distended, turn the patient, put pressure on the abdomen, push whatever is in the stomach up, clear it with your suction or glove finger if necessary, where you cannot ventilate through that. Don't try and ventilate through that. All right, now passive ventilation, very interesting technique, and I think it's something that should be considered in the Jamaican population where there is a lack of the availability for advanced life support. So we don't have paramedic response in Jamaica, right? Which is going to be necessary in certain situations. So the fact that paramedic response or ALS response is not available, it means that EMT is going to spend more time providing positive pressure for a patient. And the longer you provide positive pressure for your patient is the higher the risk of gastric distension. So one of the techniques that can be considered is passive ventilation. So this is a patient in cardiac arrest. So this is a patient that is not breathing and there is no pulse. So what can be done is a high flow device with an airway adjunct can be placed on the patient. So we put in an airway adjunct and we take a non-rebreather mask and put it over the patient at 15 liters per minute and maintain head tilt, chin lift, or jaw thrust, whichever technique is indicated. And while the chest is being compressed, a negative pressure will be created when the compression is released, and that will pull the oxygen into the lungs. So it's being passively pulled into the lungs. It follows the normal physiology of breathing, and this can reduce the risk of gastric distension. So that's what passive ventilation is. I think it's something that we need to consider in the pre-hospital setting in Jamaica because we do not have ALS available. It's going to reduce the risk of gastric distension. Now, the manual triggered ventilation device, not common in EMS, so I'm not going to put a lot of emphasis on this. You're not going to see it a lot in BLS response. You tend to see it more in the hospital setting and critical transport. When we start talk about critical transport paramedics and stuff like that, that's where you're going to see these devices. And basically, it's a device in which you put a setting based on the patient's body weight and their appropriate volume for respiration. And once you put in the setting, you watch a patient and there's a button that you press on the device that will deliver a ventilation based on the settings that it was entered in the device. My connection went down for a bit. I'm hearing feedback. Is it gone now? Good. Right, so I'm not going to spend a lot of time on that. The ATV is similar to the mechanical one. Difference is you don't have to press any device, right? You just put in the settings and it will ventilate the patient on its own based on the settings. Not something you will see in the field. See that more in the hospital. All right, now CPAP, yes, is definitely something that you will see in the pre-hospital setting. In Jamaica, you'll see it more in the hospital setting, but in the States, EMTs can use CPAP. So initially, CPAP used to be used for patients, for obese patients with sleep apnea. And these are patients who stop breathing in their sleep because their body weight is causing the alveoli to collapse. So what the CPAP does is it delivers oxygen under a specific pressure to keep the alveoli open. They started to see benefits in its use for patients in the pre-hospital setting with fluid in the lungs. Congestive heart failure patients, patients with pulmonary edema from inhaling chemicals, patients with pulmonary edema from certain types of shock. So it has benefits for those patients where they are getting high flow oxygen and the pressure that is created inside the alveoli is adequate enough to push the fluid out of the alveoli. And it prevents these patients from going into respiratory failure and arrest. So the mechanism, it increases pressure in the lungs, it opens collapsed alveoli, it pushes more oxygen across the alveolar membrane, and it forces interstitial fluid back into the pulmonary circulation. So the goal is to get oxygen in, but if fluid is inside the alveoli, the oxygen cannot pass through the membrane. So we have to push that fluid out, and the CPAP is able to do that. Therapy is delivered through a face mask held to the head with a strapping system. Use caution with patients with potentially low blood pressure, so it can cause the pressure to drop. Indication: the patient must be alert and able to follow commands. The patient must be showing signs of moderate to severe respiratory distress. The patient is breathing rapidly. The pulse oximetry reading is less than 90%. Contraindication: the patient is in respiratory arrests, if they have a collapsed lung or trauma to the chest, they have a tracheostomy, gastrointestinal bleeding or vomiting, or they are not able to follow commands. Application: resistance creates back pressure that pushes open smaller airway structures as the patient exhales. Now, complications. Some patients may find CPAP claustrophobic. It can cause pneumothorax if the patient has poor lung compliance or chronic respiratory problems. It can lower the patient's blood pressure. If the patient shows signs of deterioration, then you remove the CPAP and you start to breathe for that patient. Now, special considerations: stomas and tracheostomy tubes. Patients who have a laryngectomy have a permanent tracheal stoma. They can have a partial one as well, known as a tracheostomy. Stomas and tracheostomy tubes, continued, neither the head tilt chin lift nor jaw thrust maneuver is required. And the most common problems with patients with tracheostomy tubes is going to be the tube slip out, or they have mucus clogging up the opening. That's going to be the most common cause. So they call to get it cleared. And if you're going to suction the tracheostomy, it has to be a sterile technique, so you must use sterile gloves, and you're going to be using a flexible suction catheter. If the patient has a tracheostomy tube, ventilate through the tube with a BVM. If the patient has a stoma but no tube, sorry, hold on a sec. Sorry about that. If the patient has a stoma but no tube is in place, use an infant or child mask with your BVM to make a seal over the stoma. All right, now the foreign body airway obstruction section of the chapter, you will cover this in more detail when you cover your BLS course. If a foreign body completely blocks the airway, it is a true emergency. Will result in death if not treated immediately. In an adult, it usually occurs during a meal. In a child, it can occur while eating, while they're playing with small toys or crawling, and they put something in their mouth. The tongue is the most common airway obstruction in an unconscious patient. Causes of airway obstruction that do not involve foreign bodies include swelling from infection or acute allergic reaction. It can be trauma from tissue damage, from injury. Early recognition is crucial. Now, if it's mild airway obstruction, the patient will still be able to exchange air, but they will be in respiratory distress. And remember what respiratory distress is. Patient can still communicate with you, but they're having difficulty breathing with good chest rise, not poor chest rise, good chest rise. Noisy breathing can be present, wheezing can be present. And if you hear wheezing, it doesn't mean that your patient has asthma. Right? So if you can hear wheezing, it doesn't mean that that must be asthma. So not every asthmatic will wheeze, and not every wheezing patient is asthmatic. Wheezing simply means that the lower airways are constricted. It means the patient has bronchoconstriction. There will be coughing. With good ear exchange, do not interfere with the patient's effort to expel the object on his or her own. So if they have good ear exchange, encourage that. You don't need to do anything, just watch them. Observation. Mild airway obstruction with poor ear exchange, the patient may have increased difficulty breathing and stridor. Now, stridor is a high-pitched whistling type wheezing sound that you can hear without putting a stethoscope on the patient's chest. It is an indicator that the upper airway is in trouble. So it's an indicator that the upper airway is grossly constricted. Severe airway obstruction, the patient cannot breathe, talk, or cough. Patient may use the universal distress sign, begin to turn cyanotic or blue, and have extreme difficulty breathing. Provide immediate treatment to conscious patient. If not treated, the patient is going to lose consciousness and can die. If they go unresponsive, you follow your BLS guidelines or CPR guidelines for foreign body airway obstruction. Perform emergency medical care for foreign body airway obstruction. Perform a head tilt chin lift maneuver to clear the tongue. Large obstruction should be swept forward out of the mouth with your glove index finger. Abdominal thrusts are the most effective method of dislodging or forcing out the object. And you will use the abdominal thrust before they go unresponsive. When they go unresponsive, is CPR, with the exception each time you go to give the ventilations, you will check the airway to see if the object is visible. All right, now for dental appliances, it can cause an airway obstruction. Examples: crown, bridge, dentures, piece of braces. Manually remove the appliance before providing ventilations. Leave well-fitting dentures in place. Loose dentures interfere with the process and should be removed. For facial bleeding, airway problems can be particularly challenging in patients with serious facial bleeding. The blood supply to the face is very rich. Injuries can result in severe tissue swelling and bleeding into the airway. So with facial bleeding, the most pressing concern is going to be, is this bleeding compromising the patient's ear passage? And if it is, you need to do something about it. So control the bleeding with direct pressure and suction as necessary. And that would be the end of airway management. It's a very long chapter if you have the textbook. It is a module, and it is a very important chapter. So it's a module by itself, right? It is a module by itself. So let me stop.